that y'all might have. And then I'm gonna run and eat and caffeinate before the afternoon so I don't get hangry and ugly. Y'all don't wanna make me cry in the middle of class, right? So for the intro exam, every time I have students be like, well, I didn't really study because it was just an intro exam, which is a really poor tactic in my opinion. This material is all, yes, it is foundational, but you're going to use it all the way through the semester, which is why we start with it. And you can do really well on this intro exam and really kind of help boost you, because also there's not as much area for you to get off tracks with this material either, right? It's like the vital signs are appropriate or they aren't. This is something I should be concerned about or it isn't. Now, half of it is health assessment. So health assessment is not just reading lines off of a text or out of a book. What are you going to get when you're assessing a client in an actual nursing area? You're going to get some objective data, parent or caregiver or client reports. I might provide you with a picture because your eyes see things. Sometimes I even drop in an audio file and tell you to bring your headphones. That has happened before. Because those are the things that you're going to do when you're assessing. You're not going to be reading a textbook and be like, oh, from here I see. For this semester, in general, I know y'all did study skills with Mr. P, right? The first week or something. Some of y'all just looked at me like I'm an adult. Did y'all do some study skills? Oh, Dr. Coe took it. That's good. That's good. Okay, Dr. Coe did it. We switch things around sometimes. But she probably talked to you about, like, yes, I do want you to memorize the vital signs so that you can apply those all semester, but I'm not after asking you definitions. I'm not after asking you to recreate a table from your brain. I'm after seeing if you can take your nursing skills and the information we provide and build a clinical picture. So things that we're looking for is like, do I have further assessments to do? Do I need to be concerned about this? How would I chart this? Do I need to contact someone else about this? Is there something I need to do to keep my patient safe? Is there some teaching I need to do? Those are all your real life nursing actions. And y'all are very soon going to be real life nursing nurses. So you're going to be really doing the things. That's what we're really working on this semester. So I always get people who are like, well, I did flashcards. I mean, for vital signs, that can be helpful, but how does that help you build your clinical judgment? So better things to do would be doing NCLEX style questions and reading rationales, thinking about case studies, and make sure that every time you're studying something, you're playing like, if I was a nurse, what would this look like? Would I need to do something about this? Would this worry me or not? Do I need something else to assess or gather data on? I mean, and do I need to prepare for something from here? Like, do I need to prepare for some sort of procedure or, something like that? Like, what am I going to do about it? How am I going to know what I did work? Those are the kind of questions that, and you'll see that when we get into the disease processes, we're going to start talking about those questions more like in the class as well. Okay, now what? What do we do? What do we see? Do we have something else? So just do know that while this is foundational material for this first intro exam, intro doesn't mean it's a hand me, a give me. It means it's an introduction to the pediatric world, and we're going to keep building on it. Okay? Questions about that? Yes?
Just to clarify, last semester one thing that they would do is, like, let's say your heart rate was 105. We weren't worried about that as much.
Yeah.
Is it going to be clear cut? 30 to 60 is where we need to be.
She said, just like for NCLEX, if they're going to give you something like a lab range that ended at 3, they're not going to give you 3.1. Or if they did, it might be like, well, should you continue to monitor, or is this like a reportable thing? Well, that's a continue to monitor, that. So if I'm really trying to lead you to something, it's going to be something that should be significant. Now, one thing is, y'all are still working on building your clinical judgment because you're still students and will soon be novice nurses. So sometimes people don't pick up what I'm putting down. But I'm not gonna just go like one over and be like, that was it. Should have pulled the emergency alarm right there, because it's usually not, right? And that would be, can't even think of something where, yeah. So that, we try to make it so that you will notice if you know your stuff. I'm not saying everybody knows their stuff. So sometimes people don't pick it up. Okay, what else?
Is this more application?
Definitely.
Definitely more application.
Yes. Yep. We really try to focus so that it's the majority of applying this knowledge to different kind of clinical scenarios, because again, that's what you're gonna be doing. And that's the level that the NCLEX is on as well. So we're not only we're trying to prep you so that you pass NCLEX first time pass, and that you're going to be a safe entry-level nurse. Those are our goals. We have to do a lot of things to get there, but those are our ultimate goals. Those are y'all's goals too, right?
Mm-hmm.
You want to pass and you don't want to kill anybody. Other questions? Yes.
So 20 points, is that like 5 4-point questions or 21-point questions or a mix? Or?
It's a mix. So that's a good question. John said it's 20 points. Is that 21-point questions, 4 or 5 points? That would be mean if I gave you 4 or 5-point questions. It's not going to be that. But we do use the same variety of test questions that y'all have been seeing. This one, as an intro, it doesn't have a case study, but all of your other questions or tests 1 through 5 will. I do not anticipate, this information doesn't lend itself to like a bow tie, for example. When you're manipulating 5 points of data, it's a 5-point question. But I might give you an extended SATA or a matrix, and those might be worth 2 or 3 points. It will always be delineated at the end of the question, how many points it's worth, and if there's partial credit available or not. The whole College of Nursing follows the same rules on the partial credits, so shouldn't be a surprise for you guys. But yeah, that's a good question. It will not just be flat out 21-point questions. I would imagine, I have not got it complete yet, but I imagine we're going to end up with somewhere between 12 and 15 actual questions for that 20 points. So some will be worth more than one. Typically the ones that are worth more than one are also partial credit. Other questions? Third grade, y'all are struggling, huh? Struggle buses, yes.
Acrocyanosis is a common variation.
Yes, so he said, is acrocyanosis a common variation if it is an infant in the first 72 hours of life? Yes, because we would document it, but we don't have to do anything about it, because it's gonna go away on its own. Good question. Now, central cyanosis, never okay. That would be a significant finding, both document and do something. So whether that's clear the airway, talk to the healthcare team, we need some O2 support, whatever we're looking at there. Good differentiation.
These skin tags around the ears, we call that significant just because we have to assess the ear.
Yeah, so skin tags, you can have skin tags anywhere on your body, but we're particularly concerned if we see skin tags around the ears because there is a higher correlation of both hearing issues and renal issues. Not saying it's a 100%, but we will consider that significant because we will document it and we will do both a hearing exam and a renal ultrasound to make sure that functionally both of those systems are okay.
I don't know if this is really, but do those come up right away or is it something that develops over time?
Typically, those are ones that they're born with.
Okay.
Although people in general can develop skin tags over time in other areas, they're really common in areas of high friction, like around, bra straps, underwear straps, stuff like that. And typically in other areas of the body, it's not a concern. We can literally snip them off with scissors and it'll be just fine. So
So it's mainly when they're born and then have them right?
yes, right at the ears. Good question. Because probably, a very good chance some of y'all have skin tags. I have skin tags, so not just knocked about the ear. So that's key. Other questions? Yes.
The chart that you handed out in class, are you gonna upload that on the portal, like?
The
fill it
vital
out?
signs chart,
Yes, the team.
it should be, is it not?
Is it on there? Okay, okay, I wasn't sure.
I was gonna say, I think that and then the cranial nerves are both, should be on there.
Okay, okay. Just wanna make sure. Thank you.
Other
I just don't remember, like syndactyly or polydactyly, those finish common variations, because I don't really know what to do with you.
That's a good one. So Luke asked, what about syndactyly and polydactyly? You'll learn more about it in musculo. Those actually are significant because we can do something about it. So we would definitely document and just know that we can do things about it. But as an aside, which you'll learn more about, a lot of times for the polydactyly, especially if there's not a bone involved in that one, we'll tie it off with some suture thread and let that little tissue die and go away, and it'll fall off, and a little black nub a little while later. And then, so polydactyly, if a bone is involved, we can do surgery if parents are really concerned or it seems to really limit motion, and remove that as well. And then syndactyly, a lot of times, it's actually the bones are there for both fingers, but maybe the skin is fused, so we can actually surgically separate those and close that as well, so they'll have fully functional. A lot of times, not, we can't like make new bones if bones aren't there.
Thank you.
Yeah,
Is there a place in the book that has the pictures of what you put on there that we can see, look at it if it's significant or not?
some of those are from the book, some of those are kind of from ATI doesn't have pictures. The outline tells you what they are, but if you want me to go back in and say whether it's significant or not, I can plug that in. Oh, okay.
Yeah.
Yes.
Let me write it down. Y'all know, if I haven't told you this, then just know this about me. My adult ADHD sometimes gets in my way. And so if you ask me to do something and you do not see me write it down, the intention is here. I love y'all. I love doing the things for you. But sometimes it won't happen if I don't write it down. So add sig or variation to outline names. That's where I'll put it there, like where the names are on the outline, I'll put beside it like significant common variation, okay? And I'll upload that this afternoon. Alright, what else y'all want? 'Cause now I got a list going.
How in depth do we need to go with the training?
She said, how in depth do you need to go to cranial nerves? So first of all, you should already know your cranial nerves and what they control. Because I know for sure Miss Eagle does that in freshman. So another component is, if it's applicable for any testing anywhere, even an adult-free synthesis, whatever, previously learned knowledge is still testable now. So I would at least expect that you know how we would, or what cranial nerves are and what they control. I don't really expect at this point that you know all the variations of that, because I expect y'all to practice those more in clinic. Okay?
Like if we're the assessment, or all the assessments.
Yeah. Because I do know that's a lot.
Yeah.
But you know, if I gave you a description of something and then I was like, what cranial nerves were you able to assess from this description? Or, you know, I think that's fair game. Does that make sense? Okay, yes.
So like, if we have like a, significant comment or the comment, do we need to put, like, are y'all gonna ask like not only are they common or significant, but like how to treat it, or what would we do to follow up with treatment of it? Like
So
if they
if-
had a style, like, and we say that's a common variation, like warm towel, like would that be like something y'all want? Like-
Potentially.
Okay.
Because that's what, I mean, it would, sty, although common, would really be significant because we're going to do some
Oh,
teaching.
okay.
Does that make sense?
Yeah.
So if they were things that we discussed in here, which are some of the most common things that we would find, whether it's a common variation or significant, then I also think that that's fair game. Maybe,
On this one?
maybe. I haven't finished with this stuff yet, so. But I have done that before because listening skills are an important part of your assessment. Now, would I ask you to listen to it and murmur and then be like, is this one a PDA, a BSD, an ASD, or a COART?
Like, are you,
No.
like, are you just gonna give us something and you're like, what do you hear? Or you're like,
Maybe. It would be commensurate with what you should be able to do now. So we haven't done cardiac yet. I'm not gonna, even in cardiac, I don't ask you to identify the different.
I want you to listen to 72 audio files.
Yeah.
Man, that's a good turnout.
I know, they're nervous. They must be.
It must be.
But if I gave you, I mean, I'm not saying this is what I'm giving you, but if I gave you an audio file of kids really, someone wheezing, and like, you know, what would best describe this in your charting? Their best breath sounds bilaterally, wheezing, you know, something like that, then I think that you would be able to do that. It would be more general and broad, but hearing is an important, significant part of it. Seeing, hearing, feeling, touching, smelling. Don't lick, don't lick, no, don't lick. Ooh, that sugar, that urine sweet, we must be spilling sugar. No, I couldn't do that. That's the old timey, I don't have to do that anymore. Please don't drink urine and be like Dr. Gates said. I can see it now.
I was just wondering, on the vital signs, could you give us the age groups or the ages so we know exactly?
Yeah, I'll go ahead and add, or tell you now, but I'll add it on there. Okay, so y'all already know a newborn, it has newborn / infant. So newborn really is that first month of life, technically it's 28 days. But infant goes up to the first birthday. 0 to 1. I'll add this on the sheet and put it back up too. And then when we're looking at toddlers, so that's from first birthday up to third birthday. And so don't get all like, well, you said 1, but is that infant or that toddler? Well, on that first birthday, we switch over into toddler, okay? So, remember that. Preschool is 3 up to the 6th birthday. And then we have school age is 6 to 12, and Ida was 12 on up until technically 21 is when we end our first year of pediatrics. And that means some of y'all will still qualify as an adolescent. No, it would be like 12th birthday on up.
12 in 1 day.
Yeah. Yeah.
You're more than
What are all of this say? Adults and children. Still not appropriate, that's right. You can get way more medicine with that.
I know, and then when you're the nurse mom and you start looking like, well, hey, you weigh more than me, yeah, take it, it's fine. Yeah.
I know we're in this.
Yeah.
Oh, boy.
Okay, but I will add those in the post that. By the end of the semester, you would have known all that. How dare you not know it for your first? Okay, what else? That's why I have on a sweater. You know, if I have on a sweater, it's legit for me. Because I don't run cold.
How do we make any notes like this?
Oh, well, you need to talk to this queen right here.
Okay. Is that extra points? You can make one point?
If you can get me a better wardrobe closet than what is currently offered in the Bitmoji wardrobe, it's really sad.
It's not designed for 40-year-old women, I will tell you that. I don't think we can pass for 33, honey.
Yeah, that's
She's sucking up.
Still have a 3 in her.
Yeah, 39, maybe 30.
No.
She's older than me. Yeah, make me feel real old. Okay, anyone watch Odd Squad? Alright. Odd Squad on PBS? Oh, no. Yeah. Aiden probably never got to watch it, because he's old. Aiden can't watch TV.
The real question is she done with lecture?
Ha, no. Y'all. I do love it's because there's fluid in the stomach to make a bubble. If we're in like the pulled up in the esophagus, which it can be displaced and pulled up, or somehow managed to get down to the trachea or the airway, you're not really going to hear anything. So that's another thing. Plus, we always check our anticipated marking. But we do check placement of our marking where it's supposed to be, and we'll listen to the air bubble every time before we use an OG or NG. So especially when y'all rotate through NICU, you will get to do it because every second baby in there has one. So that is really helpful. We also do use these to check gastric contents to see if they're tolerating feeds well, or they have a whole bunch of undigested milk left in from the last feed. That could be a problem. Or are we just getting back a little bit and you can tell it's digested? That means it starts to look kind of like curdled. So there we do more than just feed through these. We also use it as part of our assessment. We can give both intermittent feeds or bolus feeds where it might be like 1 ounce delivered on the pump every 30 minutes. Or some of them might be on continuous feeds, even if they're continuous into the stomach. So our very early preemies, a lot of times they'll be on like 1 ml an hour throughout the day, and it's just a little bit in there to start getting their GI tract to practice with it, because 1 ml is not very much, right? So you can see either one of those depending on the client and what we're using it for. Whenever we have an OG, NG, or TPT we have another sphincter called our esophageal sphincter that sits right in between our esophagus and our stomach. And for most of us, it stays closed and keeps stomach content in and allows stuff in but not back out. If we have a tube there, it's already kind of open, and so we are opening the doorway to allow opportunities for reflux. So first of all, it's painful. Many of you who have experienced reflux knows that's uncomfortable, so then your person would be uncomfortable, but also it increases incidence for aspiration. So if we have one of these tubes in, we do not want them just lying flat all the time, especially while feeds are going. We want their head elevated at a 30 degree, and that's a safety measure. We do feeds at room temp, so they're frequently kept in the fridge if it's breast milk. And there's little breast milk warmers around that y'all will be able to use and see. Flushing tubes, especially if we give meds, a lot of times we'll push the meds into the tube first and then set our feed to be the flush that pushes it in. Small infants we don't give extra water to, especially our NICU babies, because they don't have room for extra water. They need calories to be in everything. So sometimes you will see someone just push just a little bit of air behind it instead of water, because it's the parameter of the area that you're at. Like, obviously an adolescent, we could totally give 5 ml of extra water behind a feed, and that's not going to be an issue. But a baby that literally weighs 1 pound, that would be an issue. They don't have room for that. So depending on where you are, how we clear the tubes might be a little bit different. And then we do always want to clamp the tube when we're finished. For one thing, we don't want air to enter the stomach, but also if you have a tube that is just open and a stomach full of milk and they start crying or pushing down the stool, what do you think might come out of the tube? What's in the stomach is going to push back up out of the tube. It's just gravity. There's nothing stopping it if you don't clamp the top. It would just be open. So you also don't want to go in and find your baby sitting in a bed full of wet milk, and you're like, well, dang, how much of your feed is still in there? I have no idea. So that's not a good thing either. So if we're not using it, we close it off. Typically, sometimes there will be an order to leave it open, hooked to a syringe, but that's a specific circumstance, like if we have them on high flow cannula to allow any overflow air to come out, so they don't have gas. But these babies, This one is an OG, and you can see we're like taped, a lot of times it's like a cannula, circle. Sometimes we'll just use Tegaderm, sometimes we'll use H-tape. It depends on your institution, really, what they use. This one obviously is an NG tube, and once they're in, they're really not super uncomfortable. So they shouldn't have a lot of complaint, even if it's an older child once it's in. They might feel a little tickle on the back of the throat or something like that. For a TPT, we can't push air into a TPT the way we do for an OG or NG, because there's not anything, everything moves through there so quickly, it doesn't stay and collect like it does in the stomach, so there's nothing to bubble around. But the other component of that is we can check placement with the syringe in the opposite way. We will use an empty syringe, a 5 or 10 cc syringe, on our TPT tube, and the plunger is pushed all the way down. You put it on the tube, and when you try to pull back, you will get a snap. So basically, when you let go of the plunger, it snaps back into place because it's almost like a vacuum in there. There's not extra room. So it will just kind of suction the plunger back down. Anytime we initially place a TPT, we do confirm with radiology by x-ray because they're tricky to get past that transpyloric sphincter. So we do have to make sure that we do have it in place, and then we kind of safeguard those. Our regular tubes usually stay in place for a week. TPTs are typically able to stay in place for a month. Every institution might have a slightly different policy, but we do keep them longer because they are harder to place. So TPTs are a butter yellow color. They're longer in length because they're going further into the GI tract. They do have numbers on them as well, just like an NG or OG. So for these, that baby just looks so happy. You would measure from either the mouth, you can place a TPT through the mouth or the nose, but you would measure from there to the ear, to the xiphoid process, and then over to the side of the rib cage. And so that's the extra length you're adding on. Make sure it's measured to sit further in the GI tract. This is what it looks like on x-ray. When we x-ray a TPT, we would do both a front up and down and a transverse across, but we expect to see it cross the vertebral column. And if you were looking at the transverse, it also angles back. So it won't just stay flat. As it enters the small intestine, it will angle back. So, but this one you can see, we've crossed the vertebral column, and I have the other view. The GT, since it is surgically placed initially, we have to be on the lookout for infection and irritation at that surgical site, and then it will heal, and at that point, they're very, very stable feeding pathways. So we would do regular cleaning of the GT area around the button. Each area has a little bit different. Frequently for us, it was some dial soap and sterile water and Q-tips, and you just clean around it. Some, especially right after surgery, might have a little residue or a serosanguinous fluid as it's healing, and we'll use like a trace sponge to kind of place around the GT in between the button and the skin. But basically, when the kids with the GT are not connected, their clothes fully cover their GT. So they'd be able to wear a normal, like a onesie or t-shirt or things like that. And then most people wouldn't ever even know they had that there unless they were looking at it or they were hooked up to their feeding. So a lot of times when people get a GT, they might also get what's called a nissen, which basically kind of narrows the top of the stomach and strengthens that esophageal sphincter to not allow stuff to come back up. Not always, but it is a frequent combination. And so they can have trouble burping, frankly. So before we feed into a GT, I'll show you the tubes this afternoon when we get out the clinical conference stuff. You'll have a tube that's a burp tube, and you'll put it to a big 60 cc syringe. Before you do anything, put that on and allow any trapped air to escape. Because otherwise it's going to go through the GI tract, and that's uncomfortable. And then you have another tube that you use for feeding. So every time that we feed into a GT, we do want to make sure that we don't just dump. A lot of times they will be on gravity, and you still want it to go over like 15 to 20 minutes so that they're comfortable. If you just dump someone's feed in there in 1 minute, you would be uncomfortable too, right? Because it doesn't allow your stomach time to accommodate. So that means typically for feeding by gravity, you have an open syringe that you allow you can lower or bring up higher to change the rate of speed that formula is infusing into the GT. Sometimes also our GT kids will be on a pump. And so that way you just have to plug in whatever they're ordered for volume over time into the pump and make sure that it stays connected. So some of those kids might only eat through the pump at night, and they might actually be able to eat some oral stuff during the day, but we're making up for nutrition they weren't able to take in, and they do that at night. So there's a lot of different variations that we will use for GT pattern feeding. Any medications, especially if we crush tablets through the GT, we have to make sure that we mix them with something and flush through as well, because it can, if we leave them to dry, it will become concrete in there, and that tube won't be painted anymore. Yes, Mona?
So it's okay if they're flat?
So for GTs, it is more, yes, it's okay if they're flat. There's not anything holding this up. Although if we're like feeding at night, a lot of those kids might still be like on a pillow or something. A lot of times those are toddlers or preschoolers. But being flat or up isn't a no-go. Yeah, so probably depend on, they might do their GT feeds up in their high chair or at the family dinner table while everyone else is eating orally, because feeding is still a social construct, so for a lot of society. So that, we have a lot more flexibility for GT feeds. That's a good question. So here are some pictures of this. You see an adolescent doing her own GT feed, and if they are able and appropriate, that's definitely something they can do. The bigger they are, they might have more feed that fits in a 60 ml syringe. If we're doing gravity feeds, you might have to add in a little at a time. That's super common. I will say for a toddler or something that might be getting more than 60 mils at a feed, if you fill it all the way up to the top and then they happen to move or bear down or do any of that, it's very likely to overflow and spill over. So, you can experiment with yourself on that, but at some point you're gonna clean up a mess. So we typically like to fill them about halfway up and then let it, drip down some before we fill more, just so that you're not changing your linens and the kids' clothes and stuff all the time. You can see there's actually lots of different tubes and lengths and types, and we'll look at some of those more closely today. I have some of y'all can actually hold and look at. And then here's what the GTs actually look like. So on the top, they just kind of look like a little button, and there's a flange that pops open for you to plug the tube in, and then when you're not using it, you just button it closed. And they're usually on the left side where you'd think your stomach is, but some end up with it a little more midline. Everyone's anatomy is just slightly different. On the inside, they have this little kind of balloon. We usually fill it up with sterile water to make sure that it's full and it's not able to pull out, although kids do sometimes also pull them out. And then what you see here, that maybe is not big enough for an actual GT button yet because of the room that this takes up. So sometimes we'll use like a flexible tube to feed into while they get a little bigger before we place the real button. That's a possibility. If they do pull it out, most of the time the parents or caregivers will bring them into interventional radiology and they can pop it right back in. It doesn't necessarily require like another surgery or anything. We'll deflate the tube, look at the side, place it back in, reinflate the balloon, and then x-ray to make sure that it's all the way through and sitting in the stomach. Okay. In general, we've already hit these. If we're going to put any sort of meds, especially meds that have been mixed like a crushed tablet or something like that, through a tube, we have to clear it somehow. If we let it sit, it will block the tube. Whether we're using these types of feeds for replacement feeds or supplemental feeds, it's still important that the child is still supported developmentally. So for our infants that are doing tube feeds, because they maybe are still too small to do oral feeds, we still offer a pacifier with their tube feeds. And they begin to associate sucking on the pacifier with the feeling of a full belly, and they're working those mouth muscles. If they're older, we might still use feeding time, whether it's through tubes or not, as quiet time to be held and rocked like a mom would do anyhow with a bottle or a breast. If it's appropriate, allowing the children to participate in their own feeds, whether that's plugging themselves up, pouring up their formula, again, that's a potential. And then, like I said to Fauna just a second ago, some kids will even eat their, tube feedings as family is eating their meals, and they'll still have mealtime all together. Okay, obviously we have to educate if we're sending them home on tube feedings, or if we're doing tube feedings in the hospital even, about how and why we're doing it and what we expect from that, what's our benefits, what's our risks. Allow the parent and child to participate, and again, that might just be mom or dad holding the child and rocking the child while the tube feed is going in, that's fine too. Talking about any questions, and if they're going home, then we have to make sure we troubleshoot, like what happens when there's a problem, because there will be problems, because life is life. Okay. For our TPN support, I told y'all already, that was a 24-hour mixture. Typically, if we're doing TPN as a supplement, they won't have lipids. If we're doing TPN as a full replacement for calories, then they will have lipids. But we do have to do that frequent lab because we make those mixtures specifically to that client's needs. It does have sugar in it, so we cannot just stop a TPN infusion rapidly, or they'll have rebound hypoglycemia because their body gets used to making a consistent amount of insulin to deal with the consistent amount of sugar we're infusing. And so if we just stop it, we're gonna bottom them out. So that's a concern, especially if we're weaning off of TPN. Y'all will see they do it stepwise. Like they'll go down by half for a couple days and then half again, and it's a process, especially the longer they've been on it. Again, anytime we're putting something in, we have to monitor what comes out. We have to, some places it's just clean when priming, especially if it's TPN through a peripheral IV, but if it's a central IV, that's gonna be sterile. And then vital signs, because if we're messing with electrolytes, y'all already know electrolytes, we could easily have reflexive changes in our vital signs if we're hypo or hyper on one of our electrolytes. Most common complications would be hyperglycemia from beginning our infusion too rapidly, and then hypoglycemia from obviously stopping it too quickly, and then those electrolyte imbalances. We can put any of those and all of those in different proportions within the TPNs. We just do have to be careful. Okay. Almost done. Urine specimens. This can be hard to collect from a child. It doesn't need to be sterile. If we can do a clean catch and parents or caregivers are willing to help, we can do that. Some kids, the younger kid, they can't pee on command. So that can be really hard. But they could use a bedpan or urinal if we're just trying to maybe look at sugars or proteins or something like that. For a teen female, especially if they have to transport the urine from the bathroom to the lab, if it doesn't have one of those doors, ask if they're menstruating so we can give them a towel to wrap around it and they're not carrying a bloody cup of pee down that. They would feel very awkward about that. Sometimes preschoolers or toddlers, if we know this is coming, we're going to have to prep them with some fluids first. That can cause dilution on the other hand if you're looking at specific gravity. And then we do have for infants what's called a wee bag, and I'll show you that in a second. It's basically like a Ziploc bag with sticky on the side that we can put around them and catch it as it comes out. So if they're still wearing diapers or something like that. So that's what a wee bag looks like. It does theoretically sit over whether it's a vaginal opening or a penis, but they don't sometimes stick very well, and then the babies move, and so you might only get a little bit. You might have to be using a pee bag several times to get enough for a urine specimen, but that is an option, especially if it doesn't have to be sterile. This is an option. Another option that we can do we can place a cotton ball in a diaper. We don't want stool on it, so hopefully we just have a pee-pee diaper. But we can actually then put that cotton ball down in a syringe and push the plunger down and squish out what was in the cotton ball. Again, that is not sterile, but we can use it for some things. So we're just looking at some electrolytes, we're looking at sugars and proteins. We can't culture that or look for leukocytes, that wouldn't be fair. But that's a possibility. And then obviously we could do in and out pack or something like that if we needed to. But that's, you'll talk more about that with GU, and it's a lot more invasive. So if it doesn't need to be sterile, we would try these other options to get us a urine sample first. We did already touch on this in assessment when we were talking about weighing, kind of like with the diapers, but the same thing with urine. Sometimes, you're gonna, I mean, it would be hard to be like, that's a full diaper, full of urine. What is full to you versus full to me? So, and y'all will see in the NICU, a lot of times we will weigh the diaper wet, and then we will subtract the dry weight of that diaper. And there are little, like, graphs posted all around. It's like, this diaper in this size weighs this many grams. And so 1 gram is 1 milliliter of fluid. So they're interchangeable. So once you subtract the dry weight of the diaper away, then you just have the gram weight of fluid, and then you can just 1-to-1 that over to, well, that's this many mils of urine. Does that make sense? So we do that a lot for those that were not able to otherwise measure, like with a Benton or a hat or a Foley or something like that. And then specimen collection. Capillary blood samples, when we just need a little bit of blood, we can use our finger, earlobe, or heel sticks. And most frequently in our younger, smaller people, we use the heel because the fingers can be really small. It's nice if we have a minute or two to put one of those warm packs. They'll be up there in the patient care area around that so that the vessels, the little capillaries are already dilated and nice and warm. You could also do like a warm wet washcloth if you didn't have a warm pack. And then we have different size lancets for different ages, and that changes how deep it goes in and how wide the little prick is. And we want to make sure we go on the outer aspects of the heels. We don't want to go right over like mid-heel. What's right there in the middle of everybody's heel? Yeah, there's a bone right there. And if you go too deep and hit that, then we can cause the necrotizing, let me fall again, osteochondritis. So we want to make sure that we don't go in the middle of the heel ever. So these are the areas that we're really looking for when we do capillary heel sticks, just right on either side of the heel, but never in the middle of the heel. Toes are not super helpful. So, you know, I know we say we can do finger sticks, but y'all will see this done a lot on our smaller kids, toddlers and down especially. Otherwise, we do obtain blood samples the same way other people do for our bigger kids, like a butterfly needle. We might have an IV set up depending on the line we have that allows a stopcock that allows a blood draw. So that's a possibility, depending obviously on how much we need. Also, if we're gonna do blood draw, even if it's just like a finger stick on a 6-year-old, the younger children sometimes don't have a good understanding of body boundaries and will be concerned when you say they're going to take your blood. First of all, you're taking what's mine and it's mine and I want it and I'm going to keep it. Also, they don't understand that they have plenty to give. So it's important that we reassure them that, like, it's okay, I just need a drop and you have plenty, and we're going to, this special Band-Aid that you picked out, it's going to take care of the rest, and it's okay. It's not going to keep bleeding. You're not going to run out of blood. That is a real fear of some kids. My 14-year-old just had a couple of labs drawn the other day, and he was like, how much blood do I have? So even he was like, that looked like a lot. Am I okay? You're fine. Well, how fast does my body reproduce it? And I was like, oh my gosh, you're fine. But, and he's older, so just especially know that that is a very common thing, and our younger children might need to do. Okay, let's take a 10-minute break while we set